Orlando. Thanks for watching. Let's talk about Bell's palsy. Bell's palsy is a rapid onset of facial weakness or complete facial palsy. It's limited to either the right side or the left side of the face. It's a benign condition. It's idiopathic. We don't know what the cause is. There's paralysis of the muscles that are controlled by the cranial nerve known as the facial nerve or the seventh cranial nerve. Can vary in severity from very mild to extremely severe and complete. You can imagine, since the facial muscles animate the face, that the loss of the ability to move the face can be quite devastating and lead to depression and social isolation and interference with the quality of life. Now, overall, when a person develops what appears to be Bell's palsy, the diagnosis is Bell's palsy in only about half of the cases. In the rest of the cases, there's some underlying cause. And sometimes that underlying cause is very important and needs to be directly addressed. The likelihood of your developing Bell's palsy in the course of a lifetime is about 1% to maybe 1.25%. About 7% or up to 10% of the time it can recur within a course of about 10 years. Seems to affect either side, right side, left side, doesn't make any difference when it recurs. Mayo Clinic evaluated recurrences and found the average number of recurrences in the lifetime was about 3, with a range anywhere from 2 to 20. It can occur at any age, but it does have a tendency to occur in mid-late life. The median age is 40. The highest incidence is people over age 70, usually because of some secondary cause. There's no racial or gender preference, no seasonal preference to the condition. Some people believe that there's a predilection in people who have diabetes or hypertension or who are obese, but there really isn't. There's a traditional thought that pregnancy is a risk factor, but it's only those pregnancies in which the woman has chronic hypertension or who has preeclampsia or is otherwise obese that there's a slight increase, not a significant increase, but a slight increase in the incidence. Now, the diagnosis or the condition comes on very acutely. So it's noticed first thing in the morning when you stand in front of the mirror, when the spouse says, hey, what's the matter with your face? So oftentimes people go to the emergency room because they think they've had a stroke. Tends to occur maximum intensity over 24 to 72 hours, over 1 to 3 days. It's not slowly progressive. So if it's slowly progressive, it's something else. Now, the weakness can be either partial or complete. It's on half of the face, either the right side or the left side. Involves all of the muscles on the affected side, from the forehead to the corners of the mouth, the eyebrows. You can't fully close the eyelids or the lip on the affected side, and there's no other explanation. So when we look at a person with Bell's palsy, the face seems to droop, they lose the depth of the nasolabial crease, the crease that runs from the nose to the mouth on the one side. The forehead looks smooth on the affected side. On the unaffected side, it could have some wrinkles. If there's still movement of the forehead, then we have to consider a different diagnosis. There's drooping of the eyelid. The cornea may be exposed, and that might lead to inflammation of the cornea because the eyelids don't completely close. The lower lid falls away from the eye itself. That leads to what we call ectropion, and that means that the tears aren't pushed through the lacrimal duct into the nose, so it can look like a person has increased tearing when they actually have somewhat decreased tear output, although there is more tearing if you have the exposure keratitis. The lips, well, they become incompetent, so you can't whistle, and you can leak toothpaste and liquid and even food from the affected side. Can have some difficulty speaking, and when you sneeze, there's no movement on the affected side. You can't raise the corner of the lip. Can have some problems with nose breathing because of the affected muscle. And in about 70% of the time, there's some pain around the ear, either behind the ear, in front of the ear, or actually in the ear itself. Now, some people complain of facial numbness, but on testing, it appears that they have no numbness of the face. That's a completely different completely different nerve. Now, there's no hearing loss. Actually, some people who have the Bell's palsy might have hyperacusis. They might have an increased sensitivity to sound because one of the muscles that's affected normally dampens the movement of the bones in the middle ear. When that doesn't happen, then everything seems to be magnified. You also can lose some of the sense of taste, especially on the front 2/3 of the tongue. It might be the first symptom, actually, and that portends a worse prognosis typically. So even though the facial nerve innervates some of the minor salivary glands, dry mouth isn't typically a problem. Also involved in the facial nerve is the platysma muscle, the muscle of the front portion of the neck. That doesn't move. Now, in physical examination, when you look at a person who has Bell's palsy, they can't elevate the eyebrow, can't close the eyes, can't frown, can't smile, pucker the lips, puff the lip, cheeks on the affected side, don't move that platysma muscle. We grade it according to the House-Brackman scale. 1 is normal, 6 is complete facial paralysis. Most people mild to moderate or even moderately severe. Well, do we need any other kind of tests? Typically no, unless there's a hint that there's a central lesion, some sort of a brain abnormality. And appropriately, in certain geographic areas, if the person has a history of a rash and some arthritis, well, we might think of Lyme disease. Lyme disease very frequently can cause what appears to be a Bell's palsy, but is really called a facial nerve palsy in that case. It's not really related to diabetes. In people who don't seem to be getting somewhat better after 2 or 3 months, then it might be appropriate to check to see if there's some other kind of an abnormality. So that's when we do some testing and look for hemangiomas, or we look for acoustic neuromas, or we might consider some nerve conduction studies or some electromyograms. But most of the time, those are inappropriate and unnecessary. And talk about unnecessary testing. Most people who have Bell's palsy end up with an MRI, but in the overwhelming majority of people, it's inappropriate and unnecessary and actually confusing, because they're normal variations that might be thought of as being part of a disease process. Now, the cause of the condition has to do with edema of the facial nerve, and it's the edema of the portion of the nerve known as the geniculate ganglion. And when the geniculate ganglion inside the bone becomes swollen, it really can't enlarge, because the canal that the nerve runs through within the bone can't expand. So as a result, when we have the edema, that blocks off some of the vascular supply to the nerve and can cause a compression neuropathy, just the same sort of thing as happens with the carpal tunnel syndrome. So it seems that the nerve runs along what we call the facial canal within the bone. The facial canal is also referred to as the fallopian canal. The same fallopian canal as the fallopian tubes runs in this canal that's about 1 inch in length. And the facial nerve controls facial expression and taste and the tearing and the salivation and the sensation to the ear. When the nerve exits the skull, it does that at what we call the styloid foramen, and that's right around the parotid gland. It runs through the parotid gland. And if you have an abnormality in the parotid gland, maybe it's infiltrated by a tumor, or it's compressed for some reason, or trauma, then you can actually have some problems with the facial nerve that, again, not Bell's palsy. And in most of those individuals, the forehead moves. So we evaluate people. We want to make sure they don't have squamous cell carcinoma in the skin or enlarged cervical lymph nodes. Now, there are 5 different branches of the facial nerve. All of them have to be involved. So we have the temporal or the frontal branch, we have the zygoma branch, we have the buccal branch, we have the marginal branch, we have the cervical branch. All of those areas have to be affected in order to make the diagnosis of Bell's palsy. Now, even when a person seems to have absolutely typical Bell's palsy, by the time people get to the major medical centers, still, having been diagnosed by the family doctor or by the ear, nose, and throat doctor, still, when they get to the tertiary medical facilities, 10, 15, maybe even 20% of the people have conditions other than Bell's palsy. So if a person has Bell's palsy what appears to be Bell's palsy involves both sides. Chances are they have Lyme disease, or maybe they have Guillain-Barré syndrome, or maybe they have sarcoidosis involving the brain, or maybe they have a condition that's known as the Malkerson-Rosenthal syndrome, where they have fissures involving the tongue, and they have periodic swelling of the lip and the face, in addition to the Bell's palsy. So we have to make the diagnosis. Is it a central brain disorder, or is it just a nerve disorder, or is it a disorder that occurs once the nerve gets to the face? Well, part of that has to do with, is the forehead affected on the side? How do the eyes move? In people who have the central lesion involving the brain, then they often can't move both eyes to the side. The normal eye moves to the side, but the abnormal eye can't move. That's a hint that it's a central lesion. Remember I said that numbness is not an issue? If the face is numb, then it's the fifth cranial nerve that's involved. So that's not Bell's palsy, of course. And if a person has what appears to be Bell's palsy but has weakness on the other side of the body, the arm and or the leg, then of course that contralateral hemiparesis means it's not Bell's palsy. The course of Bell's palsy is it seems to get better over a period of starting after about 3 weeks and continues for about 3 months. And even in people who have dense flaccid paralysis, more than 60% are going to have complete recovery. Now, if you don't have the complete paralysis, chances are more than 90% of the time you're going to have complete recovery. If the cause of the condition really is shingles involving the facial nerve, then the complete recovery is only going to be about 50%. Chance of poor outcome, the older you are, if you have decreased sense of taste or the saliva production is reduced, people who have longer time for recovery, people who have diabetic, people who have pain that isn't just limited to around the ear. People with complete paralysis tend to do less well over time than people who have partial paralysis. People can even have permanent damage to the seventh cranial nerve, damage that shows up with lack of ability to move certain part of the face. You can have corneal dryness that can occur because your eyelids don't work, and then that can cause some vision loss. You can have poor aesthetic results, difficult time speaking because of the weakness, and you can have contracture of the facial nerve, scarring of the facial nerve in effect. You can have residual weakness, and interestingly, sometimes the weakness can be paradoxical, so it looks like to the unanimated face, if you're just sitting there looking at somebody, and the other person isn't moving their face, it can look like the affected side is really the normal side. It looks even better than the other side. Well, it's easy to make the diagnosis once the person starts to move the muscles. Now, they also can develop something known as synkinesis in about 10 to 15, maybe even 20% of the cases, especially when we have severe involvement. Synkinesis is when you have an abnormal involuntary muscle contraction when you do something with other muscles. So in these people, when they smile, they could blink. Or when they blink on purpose, then they could smile accidentally, or just because that happens to be because the nerve as it's healing gets a little bit mixed up. We also have crocodile tearing. That's when you're drinking or when you're eating, you're moving your mouth, then you can tear. That's not uncommon. Well, most of the time, if you have the synkinesis, it tends to occur mostly with the more severe Bell's palsy and tends to go away after a period of about 2 years or thereabout. Now, when we talk about recurrent disease, as I said, the Mayo Clinic has given us the average number of occurrences, number 3, anywhere between 2 and 20. About 40% of the time it occurs on the same side, and about 60% of the time at least one of the recurrences is on the opposite side. We have recovery after a period of about 2 months, but it's not nearly as complete as when people have just one episode. And the cause, only 40% of the time of the recurrence, is it really Bell's palsy. In 60% of the time, there's some other underlying condition. So what are the underlying conditions? Well, it could be traumatic or neoplastic tumor, autoimmune condition, inflammatory condition, might have something to do with blood vessels or congenital abnormality. Among infectious disorders, we have Lyme disease, HIV, tuberculosis, leprosy, syphilis can cause it, Zika virus, herpes simplex virus, And when the herpes simplex virus is the cause of Bell's palsy, you don't get the involvement of the lips, the vesicles on the lips. It's just on the inside, right in the geniculate ganglion. Same thing with the shingles, although you can get some involvement, some of those vesicles or the blisters on the affected ear. We call that the Ramsay-Hunt syndrome. Some people, it's a result of meningitis or encephalitis, or it could be that sarcoidosis, or it could be neuromas inside the brain, or sometimes it's metastatic cancer, breast cancer, lung cancer, kidney cancer, tumors inside the parotid gland, or something known as an acoustic neuroma, or a lymphoma. Or sometimes it might be due to inflammation inside the middle ear, otitis media. Maybe it's due to that Malkerson-Rosenthal syndrome I mentioned. Maybe it's due to increased pressure inside the brain, or Paget's disease where the actual bone increases in thickness, or it might be due to a stroke, or multiple sclerosis. Could be due to lupus or rheumatoid arthritis, or even Guillain-Barré syndrome. Could be post-operative, or from a dog bite, or a stab wound, or a gunshot. All of those, including birth injuries, give the same manifestations as Bell's palsy, or may give the same manifestations. So have to consider all of those red flags that we have an underlying condition would occur in gradual weakness that occurs over a period of months or even weeks, gradually progresses. Maybe a person has vertigo or hearing loss, or a person has a history of cancer, HIV, or constitutional symptoms with fever or weight loss, or lack of improvement over a period of several months, or bilateral involvement of the right side and the left side, or involvement of other cranial nerves, or difficult time when they move their eyes laterally, or maybe they have a fissured tongue or facial swelling, or maybe they have a skin cancer growing right in the middle of the cheek, or they have a parotid mass, or maybe cervical nodes. Well, all of those things need to be at least superficially evaluated before we arrive at the diagnosis of Bell's palsy. Because remember, Bell's palsy is a diagnosis of exclusion. We've excluded all of those conditions, and now we say it's idiopathic. We don't really know what the cause is or was. Even without therapy, more than 70% of the people are going to completely resolve. We're going to have those synkinesis in 10, 15, maybe up to 20% of the time. And we're going to have some residual weakness in about 10, 15% of the time. Residual weakness can cause a problem if you can't completely close your eyelids. Then your cornea can dry out, it gets irritated, and it can become inflamed and scarred, and you can lose your vision. So in people who have involvement of the lids and can't completely shut them, then they need to use drops. If you use drops up to 4 times a day, you can use the standard drops with preservatives, but more than 4 times a day, you need to use the more expensive drops without the preservatives, because the preservatives can irritate the eye. And overnight, you would use an ointment. And some people, you tape the eyelid shut, or sometimes even suture it shut, or use corneal scleral lens, so that could be used. The idea about steroids. A lot of people think that, oh my goodness, I have Bell's palsy, I have to go and take the steroids. Well, if you do take the steroids, and there's some evidence that they're helpful if taken within the first 72 hours or thereabout. Certainly, if you have Bell's palsy and you go see the doctor a week later, there's no evidence that the steroids are going to do any better. And the steroids, even optimally, make you a little bit better. So probably in the mid 80% range, people are going to get completely better no matter what. If you use the steroids, chances in the low 90% category, you'll get completely better. There's no optimal therapy with the steroids, no optimal regimen. Most people believe a dose of 50 to 80 milligrams taken acutely and taper off after a period of about 10 days can help decrease those synkinetic movements that I mentioned a moment ago. Now, in 2001, the American Academy of Neurology said that steroids were probably effective, but in 2012, they changed their mind, and they said, if you use the steroids shortly after the Bell's palsy begins, then they're highly likely to improve the chance of complete recovery. But, of course, if you take the steroids, they can cause immunosuppression, and they can increase the likelihood of sepsis, infection in the blood system, or peptic ulcer, or increase the blood sugar, cause diabetes, cause high blood pressure, cause some sort of abnormality of the liver or the kidney. So That's the steroids. Well, a lot of people believe that you need to take an antiviral because there's the idea that the condition is caused by either the herpes simplex virus or the herpes zoster virus, and people believe you take the acyclovir or the valacyclovir, the Valtrex. Well, the evidence in favor of taking the antiviral medicines is very weak. And as a matter of fact, there's no good evidence that taking them by themselves is any good. There is a smidgen of evidence that if you combine them with the steroids, it might be helpful. So the American Academy of Neurology, again, looked at the idea about antiviral therapy, and in 2001 they said, it's possibly effective. But by 2012, they said there's no good evidence that the antivirals are either helpful or necessary. Other kind of therapies, acupuncture, sometimes Botox injections to help even out the movement of the sides. If a lip droops, then maybe it can be filled with some filler. Physical therapy might be of help. Surgery doesn't really have significant role. There are two different types of surgery that can, one is repair some of the damage. If the eyelid doesn't close, then some weights can be added to the eyelid surgically. But the idea about doing surgery to decompress the nerve itself in the geniculate ganglion inside the facial canal, that probably is going to lead to more harm than benefit. And interestingly, even though we call it Bell's palsy, because it theoretically was originally described by Sir Charles Bell in 1821, he actually made a mistake. He described the wrong nerve. He believed that the fifth cranial nerve was responsible for what we now know as Bell's palsy. And it wasn't until 1822 that Herbert Mayo, relative of the Mayos from the Mayo Clinic, he described that indeed it was the seventh cranial nerve. But then Charles Bell went back and he changed his original writings to indicate that he really originally meant to say that it was the seventh cranial nerve. So if it weren't for that, we would now know the condition not as Bell's palsy, but as Mayo's palsy. So anyway, the idea about Bell's palsy is that it's extraordinarily common. Your chance in your lifetime is about 1 in 60. It causes weakness on half of the face, from the forehead to the neck muscles, the front neck muscles. Some people believe it's due to herpes simplex or herpes zoster, but that's the minority of the cases. Most of the time, we have no good reason for the condition, and we don't have any great therapy for the condition. But fortunately, the condition seems to go away in the overwhelming majority of people. But remember, in half of the cases, we might have a secondary cause for the condition, and that cause for the condition might need to be addressed. So anyway, that's the story. We always thank you for watching. If you enjoyed the show, please tell a friend. Maybe consider subscribing to the show. And as always, we appreciate your interest. I'm Dr. Ken Landau.